Dear Chair, dear audience, welcome. In the next and upcoming minutes, I would like to present to you my PhD thesis, which is titled is Mechanical and Optical Properties of Enamel and Dentin. My name is Péter. I'm an MD PhD student from Department of Prosthodontics. My supervisor is Emese and my SMS is Cindy. My vision with my PhD work is to help to define dental aesthetics with the academic language of science, and my mission in that is to specify what natural looking means scientifically. And for the sake of this goal, I would like to present to you my two ongoing projects. Both of them uses the methodology of systematic review and meta-analysis. The title of the first one is The Effect of Tooth Whitening on Enamel Structure, which is a comparison of in vitro studies. Based on the different published surveys, we can define tendencies among patients regarding their dental aesthetic satisfaction. I'm almost 100% positive that these tendencies are not only true for patients, but for you as well. Based on these, most of you in this room are unsatisfied with your current dental appearance. More importantly, most of you in this room are unsatisfied with your current tooth color. What can you do in this situation? Tooth whitening. Why? Because it's an easy and a cost-effective procedure. But as with every procedure, it also has its flaws. Most of the in vitro studies report reduction in the organic and mineral component, which results in the reduction of microhardness. So my aim is to determine this change of microhardness after bleaching and possibly to offer the safest concentrations and safest usage times for patients and dental practitioners as well. Which leads to my clinical question: how the different teeth whitening methods will influence the microhardness of human enamel in vitro. Microhardness is measured through Vickers microhardness number or Knoop microhardness number. My hypothesis is that tooth whitening will decrease the microhardness of human enamel after bleaching. On this slide, you can see my systematic search, and after completing each step, I was left with 144 eligible full texts. Since, unfortunately, these experiments are not ISO standardized, we had to define the ideal experiment flow for the further statistical analysis. After the extraction of teeth, the root portions are cut off. Then we create enamel slabs, and we embed them in acrylic resin. Before bleaching, we do a microhardness measurement, which will be termed as before bleaching microhardness value. Then we do the bleaching, hopefully according to the manufacturer's instruction, and after that we have another microhardness measurement, which will be termed as after bleaching microhardness value. Although it seems nice, there are many factors that are changing among these experiments. I grouped them in two to make it more understandable. The first one is dealing with the indentation, the type of indenter, the load of indentation, and the time of indentation changes. And the second one is dealing with the bleaching agents, because obviously the concentration and the usage time of these products differ. After discussion with physicists, we came to the conclusion that the different indenters, loads, and times can be used as different experiments and different test conditions. That is why for the further analysis, we only included those that used Knoop indenter with 55-gram load for 5 seconds, because these were the largest number of articles that were found. Based on the concentrations and time, we created subsets and subgroups. Let's see the results. What is microhardness? It is the ability of the human enamel to withstand different forces in the oral cavity. Giving you exact values wouldn't be so informative. That's why we decided to create ratio of means. What is this? It is a calculated number from the before bleaching and the after bleaching microhardness value. It's a percentage value. If it's, for example, 90%, that means that the microhardness is decreased from the baseline 100% to the 90% because of the bleaching. Our opinion is that 80%, so decrease of the microhardness to 80% can be turned as clinically significant. The first subset is dealing with low concentrations of hydrogen peroxide, which is commonly true for in-office bleaching. We created two subsets in these groups because the currently available European guideline does not allow nor patients nor dental practitioners to use any products that contains more hydrogen peroxide than 6%. So let's see what we have. In the first subset, we can see that using these products for 2 or 3 weeks, we cannot experience any clinically or statistically significant damage. However, if we use them for long periods of time, approximately 6 weeks, we can see that there is a significant damage. Let's jump to the second subset. We can see as well that 2 to 3 weeks use, no significant damage, but with high concentration or 6 weeks usage, we can see that we can experience clinically significant damage. If we see the third subset, which contains high concentration of hydrogen peroxides used for shorter periods of time, which is commonly true for in-office bleaching, we can see that usage these products above 90% can cause statistically significant damage. What are the strengths and limitations? The strengths are the large sample size that we included studies that use in-office and at-home bleaching products as well. We only included those studies that used human enamel, and we included Vickers and Knoop measurements as well. What were the limitations? We used the sum of the bleaching times, different concentrations and different times, obviously, and unfortunately we experienced the protocol deviation, which means that some articles reportedly or unreportedly overused the product. We had to exclude these studies because this would shift our results in an unwanted direction. What is the conclusion? At-home bleaching shouldn't be used more than 3 weeks, while in-office bleaching shouldn't be used more than 90 minutes. The implication for practice, bleaching products should be used according to the manufacturer's instructions. That is the most important one. Patients shouldn't use at-home bleaching products more than 3 weeks. And the implication of research, the standardization of measuring methods, and the effect of pH should be investigated more carefully because we think that that can cause the reduction of microhardness. So we have partially finalized results, and we plan to submit our paper after writing the article in the Journal of Dental Research. On this slide, you can see my progress, and I would like to tell you a little bit about my second project, which is the evaluation of effectiveness, safety, and satisfaction of teeth whitening in vivo. The background is quite similar. Most of you are still unsatisfied with your current tooth color. Most of you still want to treat it by tooth whitening. But the biggest flaw reported in vivo is tooth sensitivity. It can even hit the prevalence of 93% among patients. So what I can tell you is that this flowback will occur. However, I cannot tell them how much will you benefit from this treatment. That is why our aim is to determine how much does the patient will benefit from the treatment, which leads to our clinical question: what is the benefit of tooth whitening in terms of effectiveness, safety, and satisfaction? We will measure effectiveness as shade difference, safety through visual analog scale, and satisfaction through a survey which is filled out before and after the bleaching. Our hypothesis is that the effectiveness is low compared to the occurrence of complications. The implication for clinics and for research is to determine this cost-benefit of teeth whitening. On this slide, you can see the summary, and I would like to thank you for your attention with a quote from famous dentist Stefan Bergen. Color may be unimportant to the physiologic success of dental restoration, but it could be a deciding factor in patients' acceptance. Thank you so much.
You were talking about bleaching, and then there's a standard of 6% for that. Do you know any reasons behind that, or could you explain that a bit more?
According to my best knowledge, this concentration was determined by in vitro studies, which was carried out on bovine teeth, not even on human enamel. And they determined that this was the lower concentrations where they couldn't experience any reduction in the microhardness.
My question is regarding the time factor.
Yes.
Was the concentration constant during the 15 and the longer day periods, or how often was the substance refreshed in these studies?
They were So I only included those studies that followed the manufacturer's instructions, which means that these products are used. If we talk about in-office bleaching, that means that the product is applied for approximately from 6 to 8 hours, different from different manufacturers, and then washed out, and then on the next day it is carried out in the same way. If we talk about in-office bleaching, they are used like for approximately 15 minutes, and then they wash out and then do another 15-minute application, and then they can do it 3 times.